Okay. Well, here we are back again. I'm Bob Tauber
and I'm Louise Jansen.
And we're the two instructors who are teaching online psychopathology. This week what the materials covered are personality disorders and also dissociative disorders. And a lot of the work that you've done in terms of reading and assignments has been focused on personality disorders. And for this part of the week's activities, we're going to focus more on dissociative disorders. But I think we want to say a few things about personality disorders that weren't necessarily clearly covered in the book.
Yeah, I think it's important as you read these and get some experience with them and see disorders around you to really be clear that there are personality traits that aren't considered a diagnosis for a disorder. And I see that mistake a lot in the clinic practice, where clinicians will sort of see a trait and want to generalize that to a whole disorder. For instance, everyone who's showing neediness or manipulativeness is not a borderline personality disorder. Every male who is aggressive is not an antisocial personality disorder. I mean, people tend to bandy around these terms, and it's okay as long as you're recognizing that you're looking at a trait or you're looking at something that may be transitory. I mean, people have coping mechanisms that, once they're under a lot of stress or in a psychosis, they may be reaching out for help. That may feel to you like neediness, or it may feel to you like they're trying to get attention, when indeed maybe they are trying to get help or attention for something they really do need help with. So just the caution to be, you'd be amazed at how much is bandied around in sort of a derogatory way. And as we talked about too, the client themselves, you have to be able to tell them why you've come to a diagnostic criteria. So if you're basing it on just how you feel with them personality-wise, you get yourself in trouble. Clients do have access and a lot of times to their own records. So if you're banding around a term like borderline personality disorder, that's a real disorder with some, real pain and credibility behind it. So to not use it, derogatory, or to, explain every neediness or anyone who cuts is a borderline. That's just not the case. So it's always best to just go back to the criteria, go back to what is in the codes.
So I think this is kind of a pearls of wisdom for personality disorders. In other words, I think what you're saying, Louise, is lots of folks, when they're under stress or they're really ill in other ways, can show their negative traits, their negative personality traits,
right.
Maladaptive traits will come forward, and it's important not to jump on that as necessarily a personality disorder.
Right.
Because in going back to the criteria, personality disorders are long-term, enduring, maladaptive traits that exist since late adolescence or for sure early adulthood. And they don't just exist temporarily or in just one context. If a person is narcissistic, they're going to be narcissistic in their work, overvaluing their abilities and lacking empathy of other people and such. They're also going to be narcissistic at home, in their home life, in their recreational life, and so on and so forth. It isn't, personality disorders endure across time for a long period of a person's life in space, which means this place, that place, and this place. And that's really different than somebody who is suffering a severe clinical depression and becomes very needy and dependent. And then somebody thinks they're a dependent personality disorder, and kablooey, the depression clears up and they're no longer a dependent personality.
Because it does translate into treatment. So clinicians want to sort of treat what they can latch onto and what they see. So you can miss the underlying disorder or the major disorder and get very caught up in wanting to treat. Dissociative is a good example, because there's people have very interesting states, say when they have schizophrenia, and I've seen clients who are amazingly detached from their emotions, and you could easily call that a dissociative state, or something that's not part of their serious mental illness, and then you kind of miss the boat because it translates into treatment. So
Well, anyways, back to just finishing off personality disorders before we get into dissociative. On the one hand, so we're recommending, not jumping to a personality disorder diagnosis just because a client irritates you, because in fact the personality disorders are usually more irritating to the people around the person who has them than to the client themselves. But at the same time, you don't want to miss a personality disorder, because access to is so important, because you could be trying to work with what appears to be some axis 1 temporary state, and you're working it, and suddenly you realize this is just part of a personality disorder that's been going on since the person's adolescence. So so it will be less responsive to treatment. So on both sides, it's like you don't want to jump to it for sure. It could be very stigmatizing, but you also don't want to miss the idea of a personality disorder. It takes longer to see, wouldn't you say?
Right.
I mean, in other words, a personality disorder, unless you've known that client a long time, it's not clear one way or the other. So you really have to,
right.
I think in your textbook, he says there's the mistake of premature closure, where you close the books on a diagnosis before you've gotten all the information. So personality disorder. So I think and you guys answered questions, and you did a really good job. I think we're kind of past that. So back to you're saying dissociative disorders. So we need to just do a little bit of a definition of dissociative disorders. Whereas personality is enduring traits. Not necessarily personality disorder. Personality are enduring traits. In terms of ways of behaving, like whether you're extroverted or introverted, whether you're gregarious or shy. There's thousands of words that describe personality traits. So it's ways of behaving, it's ways of perceiving the world. A person who has personality traits of, on the obsessive side, might see all the little tiny details of the world. So personality usually involves sort of a continuity of experience, of ways of thinking about the world, perceiving the world, and interacting with the world. But personalities have continuity. They're continuous. They don't just come and go. I'm sure if you think about the people that would make sense. Your family members and your friends, they have personalities. They don't just come and go. Dissociative disorders a lot of them are about these, what appear to be traits and things involving ways of perceiving, thinking, feeling, and interacting with the world that break apart and can exist as one type of personality state, so to speak, at one time, and then the person appears to have amnesia possibly for that number one state, and then has a completely separate state. And so instead of being a continuity the continuity that happens in personality disorders, dissociative disorders are about discontinuity and fragmentation of a person's recollection of what's going on in the world, of their sense of themselves as an identity, of important information about themselves. So just before we get into the granddaddy of dissociative disorders, dissociative identity disorder, otherwise previously known as multiple personality disorder. Just a quick review. There are only 5 dissociative disorders, I believe. So one of them is called dissociative amnesia, and that's where you have a break with memories and that you can't recall. A lot of the dissociative disorders, the theory is that they're linked to a trauma. So perhaps a person would experience some sort of trauma and then has amnesia and dissociates from that trauma. Another one is dissociative fugue. Also, often a person experiences a trauma, is in a terrible earthquake, and then finds themselves in a new city, and they don't have memory of who they were in the old city, or don't have have a vaguely formed new identity, or possibly a new identity. Not multiple identities, just amnesia for who they were and one newly formed identity. So that's dissociative fugue. There's also something called depersonalization. Oh boy, I hope I get it right. Or derealization disorder. I think it's depersonalization. It's really a person who is impaired and suffering from having what we used to think of as out-of-body experiences, where they perceive their body from the outside, or they look at their arm and feel detached. It's not their arm. They've disassociated from their physical being, and that's depersonalization. And then there's something called dissociative disorder, not otherwise specified. Those are for a variety of disorders, like a person who's been brainwashed or in a cult. That's called dissociative disorder, not otherwise specified, NOS, right? And then finally, we're going to pause this tape and we're going to start again. Dissociative identity disorder or multiple personality disorder, which is the granddaddy of them. The Sybil, the book Sybil and the movie, Three Faces of Eve movie, Fight Club, what other Primal Fear. I'm giving you movies for people who have multiple personality disorder.
Right.
That's most of them that come to mind right away. So what we want to do is we want to talk about that one, dissociative identity disorder, but we want to pause this tape and then we'll start it again in part 2. Right?
Okay.
Okay, thank you.